Good day, my dear students. Welcome to our class on bioethics and sexual ethics. Our lecture for today is about end-of-life issues. When a family member, a friend, or a relative is facing the cross of a grave and serious terminal illness, we cannot deny the fact that it is very painful to see our loved ones suffering. And so in cases like this, what do you think is the most compassionate thing to do? Is it right to end the suffering of the patient by mercy killing? Is it right to exhaust all means to prolong the life and suffering of the patient? Or is it right to withdraw all treatments that are futile and wait for the moment that the patient will die? What is the difference between killing a patient and allowing the patient to die? These are some of the questions we shall answer in this lecture about end-of-life issues. I shall develop 3 points for this lecture. First is on euthanasia, dysthanasia, and orthothanasia. Let us go to the first point, euthanasia. Euthanasia is sometimes called mercy killing. Etymologically speaking, it came from two Greek words, eu, meaning good, thanatos, meaning death. Literally, it means good or a happy death. Let us read this definition on euthanasia given by the Declaration on Euthanasia, a document from the Vatican Congregation for the Doctrine of the Faith. Euthanasia is an action or an omission which of itself or by intention causes death, in order that all suffering may in this way be eliminated. In this definition, it is important to highlight the intention of the doer. And what is the intention? To bring about the death of the patient to end all suffering. It means that even if the actions are carried out by acts of omission, omitting food and hydration to the patient, or by acts of commission, like for example, injecting a substance that will make the patient die, those acts are classified as acts of euthanasia. And there are different kinds of euthanasia. There is what we call active euthanasia, directly willing the inducement of death for merciful reasons, whether by acts of omission or commission. There is passive euthanasia, allowing to die, withdrawal of life supports, when such supports are no longer beneficial but harmful. Later on, we will discuss this passive euthanasia. Voluntary euthanasia, when the patient asks for it, or involuntary euthanasia, when the patient does not want death, but others choose death, which is against the wishes of the patient. There is also what we call non-voluntary euthanasia, when the stand of the patient is unknown and the patient can no longer give consent because of the condition, and the one making the decision for the patient are the family members, the closest relatives, the proxy consent. And when they impose death on the patient, that is what we call non-voluntary euthanasia. There are some countries that approve or legalize euthanasia. Examples of these are Belgium, Canada, Colombia, Luxembourg, Netherlands, Switzerland, several states in the US, and some parts of Australia. Now, what is the morality of euthanasia? Is there a right to die? Some say that given the principle of autonomy, I have a right to decide what I want to do with my life. Even a right to die, that is my right. But we should take note the principle of autonomy is never absolute because we are mere stewards of life. We are not the owners of our own lives. We are just caretakers. And euthanasia is against God's commandment, thou shalt not kill. No? In cases of voluntary euthanasia, when the patient asks for it, there is what we call physician-assisted suicide, wherein the doctors assist the patient to end their lives. No? This is clearly against the Hippocratic oath, no? Primum non nocere. In the first place, do no harm to the patient. To kill is to harm the patient. No? So we say no to euthanasia, no to mercy killing. No? The term mercy killing is actually a false sense of compassion, a false sense of mercy. It is not compassionate to kill a person. True compassion consists in genuine love of neighbor, caring for the person. True compassion is against killing. True compassion is against euthanasia. That is why our stand is no to euthanasia or mercy killing. Let us read this paragraph from the Catechism. It says here, whatever its motives and means, direct euthanasia consists in putting an end to the lives of the handicapped, sick, or dying persons. It is morally unacceptable. Thus, an act or omission which of itself or by intention causes death in order to eliminate suffering constitutes a murder, gravely contrary to the dignity of the human person and to the respect due to the living God, His Creator. That is euthanasia. Let us go to the second point, dysthanasia. Dysthanasia etymologically means faulty or imperfect death, abnormal death. And we can define euthanasia as the undue prolongation of biological life. That is, the prolongation of dying or the medical process through which the moment of death is postponed by all means available. So, if euthanasia means ending the suffering of the person by killing the life of the patient, dysthanasia is its opposite, prolonging the life and the suffering of the patient. Now, how do we approach cases like this? We need to differentiate, again, if you remember our discussion on ordinary or proportionate means of treatment and extraordinary or disproportionate means of treatment. Let us review. Ordinary or proportionate means of treatment are those treatments that, in the judgment of the patient, offer a reasonable hope of benefit and do not entail an excessive burden or impose excessive expense on the family or the community. And part of the ordinary and proportionate means of treatment are food and hydration. Food and drink, these are some of the basic things that should never be denied to the patient. A person has an obligation to use ordinary or proportionate means of preserving his or her life. So if the treatment can still address the medical situation of the patient, if there is reasonable hope for benefit and no excessive burden on the patient and on the family, then we can call that treatment ordinary or proportionate treatment. Extraordinary or disproportionate means of treatment are those that, in the patient's judgment, do not offer a reasonable hope of benefit or entail an excessive burden or impose excessive expense on the family or the community. A person may forego extraordinary or disproportionate means of preserving life. So if the treatment is futile, if the treatment is no longer addressing the medical condition of the patient, if the doctor says the situation of the patient is incurable and no treatment can address the patient's situation, we can call that extraordinary or disproportionate means of treatment. Now, extraordinary means non-obligatory. No? Ordinary or proportionate means obligatory. Now, who decides if treatment must be given or not? No? Again, following the principle of autonomy and informed consent, it is the patient. No? The physician must explain to the patient all the implications of the treatment, and at the end of the day, it is the patient who decides. The patient must give his informed consent. If it is not possible, like for example, in cases of coma or when the patient can no longer give consent, it is the surrogate that provides proxy consent. But you must remember, even the proxy consent must always be geared to the best interests of the patient. The proxy consent must choose that which the patient wishes if the patient can give his or her consent. We now go to the last point, that is orthothanasia. Orthothanasia etymologically means correct dying. No? It is allowing the patient to die, no? Letting him or her go when the time comes, not earlier, which is euthanasia, and not later, which is dysthanasia. No? Orthothanasia is not the same with euthanasia. No? Some say that this is passive euthanasia, but based on our definition on euthanasia, it is not actually euthanasia. There's a profound difference between euthanasia and orthothanasia. Euthanasia is intending the death of the patient, either by acts of omission or acts of commission. Whereas orthothanasia, death is not intended, it merely happens. There are three possibilities of orthothanasia. First, when treatment to prolong life is useless or futile to the patient, we call this extraordinary or disproportionate means of treatment. And we can let go of these treatments because these treatments can no longer make better the condition of the patient. Second, when prolongation of life is excessively burdensome for the patient and the family. And third, when the patient needs painkillers. One can mitigate or minimize the suffering of a terminally ill and dying patient by using painkillers. Although we need to take note that using painkillers has a side effect of shortening the life of the patient. No? Well, we can use here the principle of double effect. No? Death is something not intended, but a side effect of alleviating the suffering of a dying person by using painkillers. Now, what are we going to do in cases of orthothanasia? No. There is what we call palliative care. And what is palliative care? It is centered on relieving the pain and suffering of terminal patients, on caring for patients medically, humanely, and spiritually. Hospice care may be an outstanding model of palliative care or comfort care. In Christian perspective, palliative care is a form of disinterested charity. We need to take note that palliative care is part of the ordinary or proportionate means of treatment. No? And that includes food and hydration. So, the one caring for the terminally ill or dying patient must continue to give food and hydration to the dying patient. We read this paragraph from the Catechism. Even if death is thought imminent, the ordinary care owed to a sick person cannot be legitimately interrupted. The use of painkillers to alleviate the sufferings of the dying, even at the risk of shortening their days, can be morally in conformity with human dignity if death is not willed as either an end or a means, but only foreseen and tolerated as inevitable. Palliative care is a special form of disinterested charity. As such, it should be encouraged. So in summary, our discussion on end-of-life issues is a consistent yes to life, no to euthanasia, no to false sense of compassion, no to dysthanasia, to the undue prolongation of the suffering and the dying of the patient. Yes to allowing to die. Yes to orthothanasia and palliative care. Yes to God, the giver of our life. Yes to the compassionate act of caring for the patient. That would be all for today. Please take note of your assignments. Keep safe and God bless.